Hi, welcome to our podcast today. And today we're going to talk about how do we get to the root cause or source of your injury, pain, whatever it might be. A lot of it comes from training. So each of us, both of us, have a different path on how we got to where we are today. Now, for me, I got injured. I had regenerative injections. And that got me interested, and then I started taking a lot of courses in this during medical school, and that was 18 years ago. And I got into body work. I look at micro instabilities of the body. I look at alignments of the body, and we call this functional movement. So I apply functional movement with the injections of stem cells or PRP or prolotherapy. So what I try to do in my field, and the way I came to identify the problem, was through a good history and thorough physical. And the physical not only consists of looking at our typical tests that we do from a medical standpoint, but from an alignment standpoint, I feel different inflammation within tendons. I see micro instabilities of different joints, and that tells me how the body's compensating and making adjustments which could cause stress and strains on muscles, tendons, joints that shouldn't be there. And even though you may not have had a physical hard injury such as an MVA, which is a motor vehicle accident, or a fall or something that would have caused it, over time you get these repetitive pressures on a joint or over tendons that they end up giving you the tears or injuries that you might have. And so that gets me an understanding of your body, and then we utilize our imaging techniques, technology, x-rays, MRI, what we both do, diagnostic ultrasound, to much better look at the actual tissue and identify the actual source of the pain itself.
So I'm a little bit more formal trained. I did family medicine and then a sports medicine fellowship. And in our fellowship, we covered anything from several different collegiate athletes, professional athletes. We were at games usually after pretty much every day of the week. We would do ultrasound diagnostic evaluations, ultrasound injections pretty much all day, every day for the whole year. And at that point, you really start to focus on, what does normal things look like? Why is this happening? This presents this way in a younger athlete, maybe in a little bit older athlete. This one presents it this way. The damage may be a little bit more severe. So it was, the evolution of how you appreciate, you put it on top of the platform of whatever the original medicine you studied, whether it was family or emergency or internal, and then you build on that and you kind of specialize that and you focus on each areas that have to do with orthopedics, but they're non-surgical. You understand, what it takes to get someone back from surgery, but also how to prevent them from ever needing surgery, ideally at the beginning. And then I continued kind of learning as I joined an orthopedic group in Florida that did the more traditional. So we had, one person for each body part, so to speak. We had a hip replacement, we had a hand surgeon, foot surgeon. So I got to pick their brains for each one. This type of surgery requires this type of imaging, this type of recovery, and this is the type of procedure we do. So it gets complicated very quickly, and then I eventually appreciated the different facets and different aspects of orthopedics, both the traditional surgical route and now down here in the Miami office at the non-surgical, regenerative medicine route. And I approach it similar to him. I don't have quite the experience that he does in the regen world, but I look at the way the body is not properly functioning, trying to figure out why it's getting that way, whether it's through exam. I find oral history and patient telling me why, when it hurts, why it hurts, doing certain movements. Does it hurt with this movement? Does it not hurt with that movement? The description of their pain I found is very helpful. Certain things correlate with certain injuries more often than not. One of my favorite phrases are common things are common. So I like to not search for zebras in a field full of horses. But every once in a while, you do need to look for those zebras, and that's why we use as much information as we can, in terms of imaging, whether it's x-rays, MRI, diagnostic ultrasound, which is not something that you can just go into a hospital and say, hey, I want an ultrasound in my elbow. They're going to be like, sorry, we don't have someone to do that. Or if it is, you got lucky. But more often than not, they're not going to have that. So you have to find a provider that has developed the skill set in order to do that. And that's not something that they just train. That's usually fellowship training. But overall, we use kind of all of these together to try to figure out exactly what the core root of your issue is. I prefer to treat the actual injury as opposed to a symptom of the injury. You may be feeling this, but is that actually what's causing the pain, or is that just what you're feeling and the issue's over here? Whether it's, you may feel something in your knee, but it may be coming from your back. So yes, you can try to attempt to fix the knee, but you're not going to fix the issue because it's coming from the back, as a brief example.
Yeah, that's a great point. That gets us into our medical training, where we spent hours in the hospital and evaluating people and trying to differentiate what type of pain do we have. And that kind of leads us to an example. Let's take the back, for example. Let's take the lumbar spine and spine in general, really. You have multiple ligaments and small joints in the spine. And, we have to identify, are we dealing with a disc that's pushing on a nerve, creating pain, or are we dealing with these little joints or ligamentous instability, which is creating muscle tightness and causing pain, or even pinched nerves from that? And is taking a good history and is knowing from our experience what the pain should be and what it really is. And that kind of feeds into another example, like the knee. Like, okay, there's a nerve root in the back that relates to the knee, but most patients that we see from a sports and non-surgical orthopedic, most of the time it's a direct injury of the knee. And then it is really determining, okay, is it ligamentous? After we rule out the nerves, is it ligamentous? Is it tendon? Is it joint? And that's an intra-articular versus an extra-articular diagnosis. And even leading into the shoulder, another common area, are we looking at a rotator cuff? Are we looking at a labrum tear? Arthritis in the joint, or an AC arthritis, or sprain, something like that. And so then we kind of use our imaging to help us with this. We use x-rays, MRI to look inside the joints and the spine. We look at ultrasound we can actually do dynamic testing of the shoulder and of the knee, and we can actually see if there's instabilities, whereas with just MRI alone, you have to sit still, you can't move. So we do get better motion with the ultrasound. It gives us a better idea of what we call our functional movement, dynamic motion. So we try to utilize all that, utilize our mindsets. Do you have any other comments on the spine and stuff?
The spine is something I've treated a lot traditionally, and unfortunately, very common issue. A lot of people have low back pain. Sometimes it radiates down their leg. Sometimes it's both legs. And a lot of the time, I remember one patient, because I could see it in my head what he was saying, and he was like, "I have pain in my calf," and I evaluated him, and I'm like, "That's coming from your back," and he goes, "No, it's in my calf." I'm like, "I know where you feel it, but that's not where it is." And the only way I could explain it to him was, all right, think of having like an electrical socket in the house. So if you plug in a lamp into that socket, and the lamp works, you just used it a minute ago, now you change it into the socket and it doesn't work. So there's three possibilities. It's either socket, it's the lights, or it's the electrical circuit breaker, usually in the garage. Well, in this situation, for this patient, the calf itself would be the actual socket. But for the socket, it was fine. He didn't have any calf issues. The nerves are usually okay. So for him, it was actually the circuit breaker, which for him was his back. So we treated the back and his pain went away. But having people understand that even though they feel it in one area, that may be referred pain from another area. And then the question becomes, do you just want to knock out the pain temporarily, usually with steroids or something along those lines, or do you actually want to treat the issue if it's possibly to be treated? And that kind of enters the world of surgery versus regenerative medicine versus other options. And that's where a lot of the tricky part is, well, I don't want surgery. Okay, well, if you just removed one of the big treatment options, that's where we essentially specialize in, because if someone doesn't want surgery and it's a way to treat something without surgery, then we'll do what we can to allow you to be either pain-free or in as little pain as possible, and allow you to get back to the activities that you want to do. Unfortunately, some things do require surgery, and it is what it is. But the other thing I really like about the ultrasound is that, say you have a tendon injury in your shoulder, and the ultrasound of the shoulder is beautiful. You can see everything on the screen. The muscles and tendons are right underneath the skin. So you don't really have to do a whole lot to see them. You essentially just put the probe on, put a little bit of gel, and then you can probe up and down in the skin. And I'm literally showing you on the screen, and I just described kind of what you're supposed to be seeing. And you can see what normal tissue looks like, and you can see what injury looks like. And then if I'm moving and I move your shoulder, and you look on the screen and you see the tendon popping and moving, and it's not supposed to do that, and you associate it with pain, it makes sense. Oh, that's why I'm in pain. So it's a lot easier to visualize exactly what's going on, and we don't have the luxury of that with an MRI. If you move, the static essentially becomes blurry, and the image is no good. So a lot of the times we use these different modalities to try to put the best picture together. I like to, as my father, who's a carpenter, would say, measure twice and cut once. So figure out what the issue is, and then actually treat it. Because once you've already started treating it, especially if it's an injection or surgery, you can't go back and undo that. So you have to figure out exactly what the issue is before you treat it. And then once you figure out, yes, it's this and not that, then you can kind of go from there. Another thing we do every once in a while is what we call a diagnostic block, or a lidocaine block. So if there's an issue, say it's the hip, and a lot of the times hip pain can be hip, or can be back, or can be both. It really depends. So a lot of the times what we can do is you can inject a temporary anesthetic, usually lidocaine, into the hip, and if the pain goes away, that's your issue. But if your pain doesn't go away, or say half your pain goes away, then that's only half the issue. So that is, you can't really do that with an MRI. The MRI will tell you if there's an injury in the hip, but that doesn't tell you if that's where the pain is coming from. You have to figure out, is that the source of the pain, or is that just an injury that maybe doesn't really bother you? So this is where we use a lot of these different tests and use our experience to try to figure out exactly how do you approach this situation and figure out what's the best way to treat it. And sometimes it's one treatment, and sometimes it's two or three. You may have to treat a couple different things, because your source of pain is a couple different things.
Well, and he brings up great points. You're going to get a very honest, very educated diagnosis and opinion from us. We have the training. In order to do that, we discuss amongst ourselves in order to get the actual best result for our patients. And the other thing, like you brought up, was, what, we're not opposed to surgery. And if we think that's the route you need to go, we'll let you know. But our goal here as a non-surgical orthopedic clinic is to try to keep you out of surgery. And, it's that expertise, whether it be traditional, regen, is trying to utilize the best of both worlds in order to get the best results. And that's why we're building this team together at the Osteopathic Center, in order to make sure that we try to help as many people as possible.
One of the things I've noticed, transitioning from fellowship to the traditional ortho world, where everything is billed through insurance, the surgeons want to do surgery, and the non-surgicals either kind of help that out or see the stuff that doesn't require surgery. And then, down here in its own kind of little world, that is more non-surgical but also regenerative. And unfortunately, a lot of the insurance and a lot of the old school orthos haven't really accepted or caught on to what we do. So sometimes there's a disconnect where some of the stuff that we do every day that works, they never were really part of it. They don't do it. It's like they have blinders on, and I fix it with surgery, and that's how they fix it. But sometimes there's other ways, and just looking outside the box to see if there's other ways to treat something And eventually I think we'll start becoming more accepting of different treatment strategies than, just the way we've always done it type of thing. And hopefully insurance will follow suit, but that's always kind of dragging your feet.
Well, and you said it, and I think the more stuff we put together, we put together a poster presentation recently, actually in the past few weeks, about fixing a labrum in the shoulder with these injections, and we're going to do more of these. And that way, we can get it into the scientific community, get it to other doctors, and really have a good open discussion about how to fix these injuries and the best way to proceed in the future. And hopefully we get them to insurance companies, and hopefully this will be a field that insurance will cover sooner rather than later. But first step, we got to get the right diagnosis, and once we get that, then we determine what to use as far as an injection. And I won't get into that today. We have other podcasts that we discuss that in, but that's where we're, first step, let's get that diagnosis right, and then we're going to have the best chance of success.
Yeah, a lot of the times we can do some of that over the phone, or and our staff is really good. They can kind of sift through if you have something, what you need before you can really make a good conclusion. And a lot of the times we just have to see it, and sometimes even get more information before we can really put a plan together. It's not like cut and dry. This is what it is. It's all right. It's like a menu. You have this option, this option, this option. These are the risks with this one. These are the benefits with this one. Which one? What do you want to choose? And it's hard to do that over the phone or from afar. Sometimes we can, but a lot of the times we need to collect more information, and sometimes it requires your hands and kind of analyzing before you can do that. So we try to do what we can for people that aren't near one of our clinics, but a lot of the times, unfortunately, we need to collect more information than maybe someone already has.
100%. So if you were to come in and you didn't have any imaging here, we're most likely going to ask you to get that. Unless you really don't want it, because if we don't have it, we're doing a shotgun approach, and we're very educated. We have a really good idea what's going on. But if we have the imaging, we get a precision on the severity of the injury, and that is going to give us a better idea. Is one treatment going to do it, or is it going to take 3, for example? So, but thanks for joining us today, and look forward to the future.